at the same time. So bear with me for 2 seconds. Okay. All right. Oh, let me send out the live to a few persons. Orlando, welcome. Welcome, welcome, welcome. Let's see what we can do tonight over this side with some questions. All right. Remember, share the live, please. Like up the live, share the live, and follow if you haven't done so as yet. I'd really love that. All right. And for those of us who are new here, my name is Stacy. Them a go tired fi see me face. Remember that song there? Don't know if that song is still on TV. It's TV, not TV, radio. Alright, let me send out the live a little bit more. You know. They might go tired if you see me face. Alright, so let me just send this out. Alright. Alright, Seabert, welcome, welcome. Tenny. What time is it? 7:11. Alright. As usual, thank you so much for tuning in. We're going to be doing some questions here. So you can always go ahead and share up the live to your friends. Or at least 1 or 2 persons in the chat. Alright, not chat. On your page. So at least 1 or 2 persons on your page. I would love for you to go ahead and share the live. So remember to go ahead and you see that little thing up there? That heart? Yes. Remember to do your daily heart meals as well, all right? And do your comments and all of those things. But as usual, we'll be doing a ton of questions. We'll try to do a few questions here. And these are general questions. It will cover different areas of the NCLEX exam. So we'll go through A, B, C, D. And, you know, as usually, just go ahead and give your answer. And then from there, we kind of explore it if it is something that needs a little bit of a revision. All right, so it is 7:12. Should I give them a few more minutes? Yeah, let's give them a few more minutes, and then from there we'll do that. All right, but in the meantime, I only see 1 person here. Can you just drop a heart, drop a comment, say hello or something? All right, just say hello or something in the meantime while you're here on the page. All right, and as I say, if you're new here, I'm Stacy. I'm originally from Jamaica. Was trained in Jamaica, transitioned here to the States, and still working as a nurse. I do host calls as a nurse practitioner, but in my spare time, trying to be a content creator, I come out and just give free information, you know, tips, things like those. I'm enjoying it, so continue to be a part of the page, and thank you so much for always showing up. All right. All right, so I see 1 person here. Let me see if anybody is gonna come on. I need to get into the habit of scheduling this thing, you know, these live. Schedule them a little bit more so persons can be aware of it and make time. Yeah, because I think that's one of the challenges I'm having. Not scheduling and having persons knowing that I'm going live at this time. All right, so that's it. Rash, Tom Bailey, welcome, welcome, forever blessed. Mrs. Bailey, how are you doing? How was work? Indy, welcome. Yeah. Liquor Miss, welcome. You know, we have a dollar years ago by the name of Little Miss. Yeah, my mom took it and threw it in the bush. And I cried so much until I get back Liquor Miss. Yeah, Liquor Miss, Liquor Miss. All right. It's like I feel weird, you know, starting the question and answer. But anyways, I'm going to go ahead and start. I know nobody is on the live right now, but I'm going to go ahead and start answering questions, asking questions and answering them until somebody show up. All right. Oh, I should have probably sent to my... All right, Watchman, how are you, Olivia? Welcome, welcome. All right, so in the meantime, I'm just gonna go ahead and start some questions until persons show up. All right, and then from there. So nurse manager assigns, and if you're new here, remember to go ahead and follow me on YouTube as well as on YT, on TikTok. All right, and this handle is the same. It's ThinkNursing, one word. So go ahead and subscribe to both page or follow me on the other page and be a part of the channel. All right, I do share long form contents over there. The stream, just in case you miss it, will be over on that page, so you can always revisit it at any time. All right, so we're gonna start off with the first question. Okay, nice. Watchman, we're gonna start off with the first. I'm doing good, just a little bit tired, feeling a little bit tired. I guess probably after the little exercise that I did. I don't get any rest as yet, so just feeling a little tired, but otherwise I'm good. I'm fine. All right, so the first question: a nurse manager assigns a new graduate to a patient with end-stage COPD who is short of breath and requires frequent nebulizer treatments. The new grad asks for help and the manager says, "You'll be fine. Just ask someone if you need help." Which action by the manager is most appropriate? A, Nikki 15-5, Hola. Allow the new graduate to continue and check later. B, reassign the patient to an experienced nurse immediately. C, provide bedside mentorship and supervise the new grad. Or D, report the new grad to human resource for incompetence. Carousel, welcome. Stacy D, welcome. All right, so you have a nurse manager who assigns a new graduate to a patient with end-stage COPD, who is short of breath and requires frequent nebulizer treatments. The new grad asks for help and the manager says, "You'll be fine. Just ask someone if you need help." Which action by the manager is appropriate? A, allow the new grad to continue and check later. B, reassign the patient to an experienced nurse immediately. C, provide bedside mentorship and supervise the new grad. Or D, report the new graduate to human resource for incompetence. Melva Watson, welcome. Melva says C, all right, which is to provide bedside mentorship and supervise the new grad. Definitely. All right, so managers must ensure safe staffing and provide supervision and mentorship when assigning complex patients to less experienced staff. Immediate reassignment may be unnecessary if supervision is provided. All right, so as long as you have supervision available, then you can always go ahead and act in the capacity to mentor that person while they have that difficult patient. All right. Allow the new grad to continue and check back later. That is a safety problem because it's a new grad. She's not comfortable with something, or she might not be familiar with the diagnosis, the condition of the patient. You understand? So that is going to be a safety issue. So definitely that's not one. Reassigning the patient to an experienced nurse immediately is not an option. As long as you have somebody that's able to mentor that person, supervise that person, then, allow them to take on that responsibility because there is always, the need for learning. All right. Report the new grad to human resource for incompetence. It's a new grad, so definitely not. All right. So the best answer is to provide the mentorship and supervise that new graduate. All right. A client with altered mental status signs is brought to the emergency department. Which intervention has the highest priority to protect patient safety? So you have a client with altered mental status that is brought into the emergency room. Which intervention has the highest priority to protect the patient safety? A, apply soft wrist restraints. B, place the bed in lowest position and pad the rails. C, start a continuous IV infusion, or D, administer a PRN or as needed sedative. So you have a patient that is altered that is brought into the emergency room. Which intervention has the highest priority to protect patient safety? Is it A, apply soft wrist restraint, B, place the patient in the lowest position in bed and pad the rails, C, start a continuous IV infusion, or D, administer PRN sedative? C Carousel says B. Hi, welcome over by YT. Thank you guys for tuning in. All right, so definitely you want to place the bed in the lowest position and pad the rails. All right, because as I said, this patient is altered. All right, so and you're trying to protect the safety of the patient. All right, so always make sure your bed is in the lowest position, even if the patient is not altered. You understand? They came in, they're walking, they're talking, oriented and alert, and they're with it. Always leave your bed in the lowest position for safety reasons. All right. Start a continuous IV infusion is not, the highest priority here. Administer PRN sedative. Always start off with something light, mild. Things that you can do to encourage, or prevent any form of falls or anything is always pretty good. Sedatives, yes, sedatives are okay, but at the same time, remember that the patient is confused as well. All right. Apply soft restraints. Restraints are always last resort. All right. So if you can avoid restraints, stay away from that. Sparks, welcome, welcome, welcome. Thank you for the heart, me. All right. So environmental modifications to reduce fall or risk or injury risk are priority while further assessment is done. Restraints and medications are last resort after alternatives have failed. All right. A nurse receives a telephone prescription. Oh, I think I saw one person who had answered. Sorry. Watchman and Melville had said B. Yes, to place the bed in the lowest position and pad the rails. Nice. All right. A nurse receives a telephone prescription for an antibiotic, which is required before implementing the order. So a nurse receives a telephone prescription for an antibiotic, which is required before implementing the order. A, immediate administration and chart later. B, prescriber's signature on a chart within 24 hours only. C, read back and document medication, dose, time, and prescriber. Or D, ask another nurse to validate the need. All right, so you have a nurse that receives a telephone prescription for antibiotic, which is required before implementing the order. I see a few C's. A, immediate administration and chart later. B, prescriber signature on the chart within 24 hours only. C, read back and document medication, dose, time, and prescriber. And D, ask another nurse to validate the need. C, definitely correct. All right, so read back and document medication, dose, time, and prescriber. Is very important. All right, so telephone or verbal orders requires read back verification and documentation of the order, prescriber, and time to reduce error. All right, sometimes you can always put the phone on speaker, so you can always have another nurse listen to the order as well, so you can have them to say, okay, then X was the nurse who witnessed, or was there at the time when you were taking the order, just in case you want a second person there. And it's always good to have a second nurse as well, you understand, to validate the order. The prescriber signature on the chart within 24 hours is very important, but because they put only there, you'd ignore that, that option. Immediate administration and chart later, no. You want to make sure that you have the correct order, and then from there, verify all of the different checks that you need to do, and then you administer. All right, and you don't chart later. You administer now and you chart at the same time. All right. During a mass casualty incident triage using START, which is START, which victim is tagged yellow? A, not breathing after airway repositioning. B, respirations greater than 30 breaths per minute. C, respirations less than 30 breaths per minute with a radial pulse present and can follow instructions or command. D, no radial pulse with altered mental status. So you have a mass casualty triage going on, and they're using the START acronym or mnemonic. Which victim is tagged yellow? A, the patient that is not breathing after airway repositioning. B, respirations greater than 30 breaths per minute. C, respirations less than 30 breaths per minute with a radial pulse present and can follow commands. And D, which is no radial pulse with altered mental status. Which patient are you going to tag yellow? All right. Let's pull that up. I haven't seen this. I did mass casualty years ago. C. Carousel says C. Okay. So C. Okay. Do we have anyone else? Melva says C. Okay. All right. So start mass casualty triage. Use the START, which is simple triage and rapid treatment. So that's a mnemonic. So START means simple triage and rapid treatment method to quickly categorize patients into one of 4 color-coded groups: red, yellow, green, black, based on their ability to breathe, their pulse, and their mental status. This rapid assessment should take no more than 30 seconds per person. All right. First, ask all walking patients to stand up and move it to a designated area, tagging them green. All right, which is minor injuries. Then assess the non-walking patients using the following steps. And we talk about respiration, open the airway, perfusion, checking their radial pulse and mental status, asking the patient to follow simple questions. All right, so respirations, if the patient is not breathing after the airway is open, then they are tagged black, or because they're deceased or expecting to die. All right. If the patient is breathing, move to the next step. All right. So that's for respiration. You open the airway, and then if the patient is not breathing, you tag them black. And then if the patient is breathing, you move to the next step, which is perfusion. You check perfusion by checking the radial pulse. If there is no radial pulse, you tag them red, which is immediate. If there is a radial pulse, you move on to the next step, which is their mental status. Ask the patient to follow a simple command. If the patient is confused and cannot follow a simple command, you tag them red, which is immediate. If the patient is responsive and can follow commands, you tag them yellow, which is delayed. All right. So I see Carousel and Melva says C, which is respirations less than 30, radial pulse present, and can follow commands is the one you're going to tag yellow. Because remember, the ones that are tagged yellow are the ones that, as I say, respirations less than 30, radial pulse present, and can follow commands. All right. Not breathing after airway positioning, repositioning. What would you tag that patient as? So not breathing after airway repositioning. What would you tag that patient as? Thank you for liking up the live, Carousel. Black. Okay. Respirations greater than 30. What would you tag that patient as? Thank you, McConnell. What would you tag the patient that is red? Definitely red. All right, and we say the respirations less than 30. Radial pulse is yellow. No radial pulse with altered mental status. What would you put that one as? So this patient has no radial pulse with altered mental status. What would you tag this patient as? Red. Okay. All right. So START acronym, as we say, it means simple triage and rapid treatment. For this START, the yellow one is delayed, and those are with respirations less than 30. Perfusion is adequate and able to follow commands. All right. So just in case you never know, now you know. All right. A nurse finds an unconscious adult in a hotel room with agonal respirations. After calling for help, the next step is to A, start chest compressions only. B, open the airway and check breathing. Begin CPR if absent. C, leave to find a defibrillator. Or D, insert an oropharyngeal airway before CPR. So a nurse finds an unconscious adult in a hotel room with agonal respirations After calling for help, the next step is to A, start chest compressions only. B, open the airway and check for breathing. C, leave to find a defibrillator. Or D, insert an oral pharyngeal airway before CPR. Denise, welcome, says to start CPR. Do we have anyone else? Welcome, Blackberry. All right. Anyone over YT here? No? Okay, so we'll move on. So definitely correct, Denise. You're gonna go ahead and start CPR. So you open the airway and check breathing and you begin your CPR there, all right? So immediate airway and breathing check are needed. Begin CPR if not breathing or they're having only agonal gasping, and then you get your AED and help, all right? So leave to find a defibrillator. No, you always want to assess your patient and start, you understand? Start your chest compressions there. And insert an oropharyngeal airway before CPR. I don't think anybody walk with a oropharyngeal airway. All right, so that's out of it. All right, which is the best action if a patient refuses a procedure after signing consent? So you have a patient that signed a consent and then refusing the procedure. Them say, oh, but I want this procedure again. It's too risky. What is the best action for you as a nurse? A, proceed. B, notify the physician and delay the procedure. C, document refusal and inform the physician, do not proceed. And D, ask the family member to override refusal. So which is the best action? So somebody already write up and say, yes, I'm ready to do the surgery. But then them say, no, sir, nobody wants the surgery here, when they reach on the table. Them say, no, sir, I changed my mind. What is the best action? C. So leave, C is to document refusal and inform the physician. Definitely. All right, so remember the consent is voluntary and they have the right to revoke that at any point. All right. So refusal must be documented and the physician notified. All right. Do not proceed just because they have some paperwork. All right. Do not force them. All right. If they want to leave their appendix in, you understand, to rupture, as long as you educate and you document and all, then that's the only thing you can do. You understand? Just document what you did. And you can always get a second person to co-sign. That's what I always do, especially whenever you realize it's something that is very detrimental. Just go and find somebody else to come in and witness, that conversation. And then you just document that, oh, there was a second nurse. At least that's what I do. All right? And then from there. Because the last thing you want is for you to, go ahead and document and then you hear say, oh, the nurse never tell me anything. At least you have somebody there to say, you discuss it with that person, in the presence of that person. Yeah. A nurse is delegating tasks to the unlicensed assisted personnel. Which task is appropriate to delegate? A, administering oral hypoglycemic medication. B, measuring and documenting intake or output for a stable post-op patient. C, performing dressing change for a new central line. Or D, assessing lung sounds on a patient with COPD. So a nurse is delegating task to an unlicensed assisted personnel. Which task is appropriate to delegate? A, administering oral hypoglycemic medication. B, measuring and documenting intake or output for a stable post-op patient. C, performing dressing change for a central line. Or D, assessing lung sounds on a patient with COPD. Then it says D, which is assessing lung sounds on a patient with COPD. And Carousel says B, measuring and documenting intake and output for a stable post-op patient. All right, so Denise, that one was incorrect. So the D is incorrect. Assessing, remember, your nurse, your RN, is going to do that initial assessment. All right, and remember the different roles of your support staff. All right, so your unlicensed assisted personnel is good at measuring and documenting intake or output on any patient that is stable. Administering or medicating any medication is going to be for your RN, your LPN, depending on the medications. Performing dressing change for a central line, definitely going to be for your nurse. All right. Assessing lung sounds on a patient with COPD is assessment. So that's going to be for the nurse as well. All right. So your UAP can assist with routine, stable data collection, like your intake and output. Meds, sterile procedures, and assessments are your RN responsibilities. All right. So just make sure you read on the different responsibilities so you can be familiar with that. All right. A nurse. Oh no. You suspect a co-worker is impaired. What's your best action? All right. So you're going to work and you realize that this nurse seemed to be under something that is, not so right. What is going to be your best action? A, report to the unit manager while your co-worker is still working. B, wait until the co-worker makes an error. C, confront and ask them to go home. D, ignore if their workload is heavy. All right, so you suspect a worker is impaired. What is the best action? A, report to the unit manager while co-worker is still working. B, wait until the co-worker makes an error. C, confront and ask the co-worker, ask them to go home. Or D, ignore if their workload is heavy. Carousel says A, report to the unit manager while the co-worker is still working. Definitely. You don't wait until them go home, all right? You don't wait until them go home, because especially if they're impaired and they're thinking that they're diverting, that is the best time, all right? That's the best time for them to actually get that little check. All right, that little checkup. All right, wait until the co-worker makes an error. No, always think about safety first. So safety of the patient is very, very important. So always think about the patient's safety. And think about your co-worker safety too, because if them look impaired, them need some rest. So them need to probably go home, all right, or get on a bed, get some IV fluid and flush out some stuff. So you're looking out for them. So always go ahead and report it to your unit manager. Some persons are going to be upset at you, but them don't have to know it's you though, because when you make that report, you do it discreetly, all right? So you realize that there's something going on, you do it discreetly. Sometimes you have some managers doing You have some managers who will go back and tell the folks, especially when they're friends. Because I've been at a hospital and that happened to a nurse. You understand? And it wasn't a nice thing. Because the guy got fired and he threatened the hospital and all of those things. They have to end up changing the hospital door, the door code, because he was one of the supervisors on night shift. But I found out that he was diverting. Sometimes you call for a code stroke and this man come down there and snore, stand up looking like this. Yeah, so for persons like that is very obvious and everything. You have to make that decision. All right, you can't see certain things and ignore it. But him always look like something wrong. All right, so just make sure you do it discreetly. All right, so protect your patient safety. Protect your patient first. So protect patient safety. Report suspected impairment immediately to management, so co-worker is removed from the practice. All right. As I say, don't confront them or ask them to go home, because then you can actually spiral into something different and you don't want that to be happening. Ignore if their workload is heavy. No, don't ignore it, all right? Because then they're going to be even more at risk for endangering the patient, all right? So try not to have that be happening with you. All right, so report the situation to the manager while the co-worker is still working, all right? A newly hired RN is completing orientation. Which topic should the preceptor emphasize first? So a newly hired RN is completing orientation. Which topic should the preceptor emphasize first? A, documenting software features or documentation software features. B, hospital code rapid response activation process. C, how to order supplies. Or D, staff parking policies. So a newly hired RN is completing orientation. Which topic should the preceptor emphasize first? A, documentation software features. B, hospital code rapid response activation process. C, how to order supplies. Or D, staff parking policies. So if you're orienting someone or if you're on orientation, what is the first thing you want to know? Denise says B, hospital code rapid response activation process. Okay, nice. Anybody else? Thank you so much over by YT. Definitely, yes. Melvin Carousel. You definitely want to, emphasize hospital code rapid response activation. process. And most units or most hospital always have a little policy manual. Just know where it is. You understand? Just always ask about it. When you go on the floor, just ask about it so you can always have it, or you know where exactly it is so you can have it whenever you are, in doubt about something, you can always rush towards it to find out that information. All right, how to order supplies is on the back burner. Yeah, we're not really, we're not in charge of the floor yet. Staff parking policies, definitely you need to know that, because you don't want any ticket and you don't want it to be a case after working your long shift you realize that your car get moved on to them towing places name. Yes, yeah, you don't want that to happen. I remember working at a hospital and that was the situation. After the shift, not my car, somebody else's car. I remember it was snowing in Maine. Them take the nurse car and carry the car, go all the way away. You understand? So you need to know that, but the most important thing is for you to yes, Angela, thank you. The most important thing is for you to know, like, your rapid response code process. You need to know if a patient fall, what you do. If a patient is having stroke, what you do. If you have a patient that comes in with chest pain, what to do, fire, things like those. All right. And it all involves safety of the patient, safety of everyone. All right. So emergency procedures affect patient safety and must be learned immediately or early. All right. Priority action for an RN who finds a med error that reached the patient but caused no harm. What is that? Is it A, document in incident report only? B, inform the prescriber and document facts, complete an incident report? C, wait to see if patient develops symptoms? D, alter the medication record to hide the error. So you have what is a priority action for an RN who finds a medication error that reached the patient but caused no harm? A, document in incident report only. B, inform the prescriber and document the facts, complete the incident report. C, wait to see if the patient develops symptoms. Or D, alter the medication record to hide the error. B, nice. All right, so definitely you want to go ahead and inform the prescriber and document the facts and complete the incident report. All right, we're not going to cover up anything. So document the incident report only. That one is out because of the only section of that. All right, wait to see if the patient develops symptoms. No, we're not going to wait. You understand? We don't want the patient to start develop symptoms and then we start acting. Go ahead and report it so we can always, get medications if needed to prevent any symptoms from happening. All right. Alter the medication record to hide the error. No, you're not going to do that. All right. That is illegal. So inform the prescriber, document the facts, and complete the incident report. And remember, you observe your patient and all of those things. Monitoring vital signs, depending on what the medication is, go ahead and do all of those things. All right, so transparent disclosure and documentation. Notify the prescriber and file an incident report is required. Altering records is illegal. All right. Thank you guys for liking up the live. Carousel, see how work your finger tonight. Thank you so much. All right, thank you. All right, so any questions so far? Any questions? Thank you. All right, so a nurse learns HIPAA protected information about a celebrity patient. Which action is most important? So a nurse learns HIPAA protected information about a celebrity patient. Which action is most appropriate? A, discuss the details with the friends outside of work. B, update family members as requested. C, share information only with staff directly involved in care. Or D, post a de-identified summary online. So a nurse learns HIPAA protected information about a celebrity patient. Which action is most important? A, discuss the details with friends outside of work. B, update family members as requested. C, share information only with staff directly involved in care. D, post a de-identified summary online. So C, nice. So share information only with staff directly involved in care. All right. And we talk about the staff. We're talking about the people in the department, not the ones in the next department. All right. I remember the first time I met a celebrity and I tell us to give an injection on the bottom, you see? I mean, it's a lot of mercy. Can you imagine? Poor me. At the time I was a student nurse. I mean, I said, poor me. Look at that. You understand? But certain things go with it to the grave. You understand? So you always remember your HIPAA and try not to violate it. You might walk in one day and you just have a patient that is like the biggest superstar. Yeah, man. You just have to, you know, be confidential is a must. Yes. You just have to keep your cool. Yes. You want everybody to know that, yes, you meet Beyonce, you meet, you know, Chris Brown or whatever. But no, not like that. You hear there? Not like that. So definitely do not share information outside of the persons that are, you know, directly in taking care of the patient. And it's the same thing when it comes on to staff. Even if the staff comes in and let me see what's happening here, because this happened a while ago, you know. Anyways, let me see. Do not come in my life, please, and thank you, because my son come in the life almost about 3 seconds and me get a violation. So apparently he's under the age of 13, so he can't be on the live. But anyways, what was I saying again regarding the HIPAA? I was saying something regarding HIPAA. We're talking about, it slipped me. Bring my chain of thought. All right, but anyways, in the meantime, I think it will come back. All right. I guess I was a little bit with the situation there. But anyways, the HIPAA. Okay. All right. Thank you. The staff. I think it will come back. Yeah, I was saying regarding the staff. So even though sometimes, you know, you might have persons that are coming into the department, if I realize that one nurse is caring for that person, me not go over there. If they're a staff, I'm not going over there. Do not, you know, I try not to get my name tied up in any patient's chart or staff chart. You understand? If there's one nurse that is taking care of that person, I just let them deal with it. As long as the patient is not dying. If that staff is stable, I stay away from it, because I don't want it to be a case where, even though I'm in the department and I probably can bring one little medication in there, I try to give them that kind of privacy. All right. I try to give them that kind of privacy. So if you find somebody that comes in your department, and even if they're working in your department or in the hospital, not necessarily the department, and you're caring for them, as long as they're stable, just let the one nurse deal with them. That's how I look at it. You understand? Just give them that little privacy, because you don't want it to be a case where at the end of the day you hear about 10 different persons go in the room and everybody come out now as sus. Because you know we're nosy. People very, very nosy. That's just it. You understand? So don't let it be a case because you're in that department. You just feel as though you have a need to go in there. You have a right to go in there and take care of that person. No, if they're doing the EKG and the patient not dying, let one person just go in and just deal with that stuff. And that was just it. All right. So as I say, you do not share that information. All right. You do not share any information. You share it only with the persons that are involved directly in their care. All right. So PHI may be shared only with those who have legitimate need to know for care. Sharing outside is violation. And some facilities that you go to, you might realize they have this thing called break the glass. You know, because them know so one of us are very nosy, you know, them know that we are so nosy. So them have this thing where you definitely have to go in the chart. If you definitely need to go in the chart, you have to put in your passcode, and you have to put in if you are a nurse, if you're a provider, if you're a tech, whatever your role is as to why you go in that chart. So if you're not doing anything related to that person, HR is going to get a little, you know, some little notification say you're going to the people in chart. You understand? They know who go in the chart. So make sure you go in the chart only if you need to go in that patient's chart or that staff chart. All right. Which is a centennial event that must be reported to the Joint Commission? So which is a centennial event that must be reported to the Joint Commission? A single medication omission with no harm. B, a fall with serious irreversible harm. C, a minor documentation error. Or D, a late lab result without harm. So which issue is centennial? Which issue is a centennial event that must be reported to the Joint Commission? A A single medication omission with no harm. B, a fall with serious irreversible harm. C, a minor documentation error. Or D, a late lab result without harm. So Doc E, welcome, says B. Carousel says B. Yes, a fall with serious irreversible harm. All right. So sentinel events include unexpected events causing death or serious harm. Example, fall with major injury, and those must be reported and analyzed. All right. So you don't want your name go to, the board or anything like that. You don't want to lose your license. Sentinel events are things that, do happen sometimes. And these are the things that people lose them license about. You understand? I think I remember, what medication was that again? There was this alcoholic patient and the nurse lose her license because of it. So she was supposed to give the medication. It was supposed to be an IM. I haven't done that medication for a long time. So the patient was supposed to give the medication IM. Both of them were travel nurses, and she was about to push the medication, and her friend went in the room and actually saw her and literally had to push, literally push her hand away from that IV because she was about to give about 2 mils of a medication that would put that patient in immediate cardiac arrest, and she lost her license for that. So think read upon near misses as well. All right. Read upon near misses and make sure you're familiar with that. Let me just put it up. Near miss events. All right. So a near miss event is an unplanned occurrence that can have a potential to cause injury, illness, or damage, but did not. Such as a co-worker slipping on a wet floor without a sign but not failing. Those close calls are critical because they reveal underlying hazards that could lead to future accidents. So reporting them, whatever, blah, blah, blah. All right, so in some states, they have them when as it is related to medications. I know the state of Maine does have one. So read on the different state and regarding near miss event and see what it entails. All right, so make sure you look out for that as well. So if you hear about anybody about to give, say, for example, IV push potassium, but they never give it yet, you know what potassium does. You understand? Once you push that is a problem. Them dead. So things like that, people will lose their license even though they've never, they haven't actually injected the medication in. All right. Because if that person ever go in and break that, that injection, stop that person, then what would have happened? That patient would have gone into cardiac arrest and died. You understand? So read on near miss events and make sure you're familiar with it. All right. And then from there. All right. Hospital policies. Oh, remember to go ahead and top up the live, guys. Thank you. All right. So who is over by YT here? Can you say hello? All right. And if you're new here, I'm Stacey. Thank you so much for following. All right. We do live stream on Tuesdays and Thursdays for NCLEX questions or NCLEX type questions. All right. So it's more just studying we're doing. All right. And then from there, them always run off of YT. I don't know what's happening with YT. As soon as I say hello, them gone. All right, let's go. So hospital policies requires influenza vaccination unless exempt. A nurse refuses for non-medical reasons. The best response by the manager would be A, to terminate immediately. B, discuss exemption process and alternative measures, such as masking and enforcing the policy. C, allow nurse to work on mask. Or D, ignore because it's their personal choice. So hospital policy requires influenza vaccination unless exempted. A nurse refuses for non-medical reasons. What is the best response by the manager? A, to terminate immediately. B, discuss exemption process and alternative measures and enforce the policy. C, allow nurse to work on mask. Or D, ignore because it's her personal choice. Carousel says B, definitely. You want to go ahead and discuss the exemption process and alternative measures such as masking, all right, and enforcing the policy. All right. Ensuring patient safety while following employer policy is very, very important. But me never know say as a flu the body no, and I never know say as a flu dangerous until me come off foreign. I didn't know that influenza was that awful. I tell you, when I just moved here to the States in 2016 and I started working in this hospital in Maine, may I tell you, it's full suit of PPEs from head to toe. Hair net, shoe cover. When I tell you, the only time I see that amount of PPE is when, COVID hit. You understand? In comparison to, because at that time, when you go in a patient's room, oh my word, and that's why that hospital was doing so well. That hospital was doing so well during COVID, because when it comes on to wearing your eyewear, your face shield, they might do that from 2016 with flu patients. You understand? So I never know it was that dangerous, but but terminating immediately is a no-no. All right, they have a choice, but they just have to go ahead and make sure they're wearing their proper PPEs. That was one thing. Once they step in the hospital, they had to put on their mask because the masks were out at the front. All right, ignoring is a personal choice. That's fine. It's their personal choice. But at the end of the day, they're working around persons that, are at risk. At the hospital, so you need to wear a mask or you need to get a vaccine. You just have to go with it if you still need to keep a job. All right. Allow the nurse to work on mask. No. All right. That's a no-no. As I say, enforcing the policy and patient safety is always going to be important. All right. Because you have those patients that are compromised as well. So you want to go ahead and protect them. Which documentation in handoff gives the receiving nurse, the best patient safety information? So which documentation in handoff gives the receiving nurse the best patient safety information? A, stable, will be fine. B, S-bar, including current status, recent changes, and anticipated needs. C, complete medical record only, no verbal report. Or D, see charts for detail. So which documentation in handoff gives the receiving nurse the best patient safety information? A, the stable patient, he will be fine. B, S-bar, including the current status, recent changes, and anticipated needs. C, complete medical record only, no verbal report needed. Or D, see chart for details. Hi, Renorta. Carousel says B, which is the S-bar. All right. Melva says B. Okay, nice. Yes. So always use your S-bar when you're doing any form of report, handoff, or anything like that. Brene, Lou, welcome. Thank you. All right. So always use your S-bar when you're doing any form of report. A lot of times we tend to be doing it, but we don't know that it is actually S-bar. So let's just pull that up. What does S stand for again? So S-bar, situation, background, assessment, and recommendation. All right. So that's what we're always. You might call the doctor and say, hey, doc, Stacy over by this room, having this problem. It's the same S-bar. All right. It's the same S-bar we're using. Situation, background, assessment, recommendation. All right. You talk about what's happening. You give a background as to the patient, because sometimes you might have a different provider that has taken over the care for the patient. So you just want to give them an idea of what the patient or who the patient is. Assessment, you tell them what's going on, and then the recommendation is what they order or what you're suggesting as well, what you did for the patient. All right. So S-bar provides concise, relevant information supporting safe transition of care. A lot of times you tend to say see chart for details. And sometimes you go looking at the chart and the chart empty. Nothing knowing at the chart. You understand? Not a thing knowing at the chart. You probably see a triage note and you see probably you probably see a triage note, but there's nothing in the chart. You can't even have a mental picture as to what is happening with the patient. So see chart for details. No, always put out some, really good information. So that way, in the event that 2 months later you are called and you're supposed to go back, you can actually see what you had documented. You understand? You can have a mental picture of what is happening with that patient or be reminded about the patient. Complete medical record only, no verbal report. It's always good to give your verbal report. All right, ask questions. You go ahead and you ask questions. A bedside report is another thing. Go to your bedside and you ask your question. Go to the bedside and you ask questions so patient can hear. You understand? Because sometimes we might say things, and I'm not saying that we're dishonest, but a lot of times you might hear persons say that, oh, the patient getting medication. The patient not getting medication. You understand? The patient is over there crying, but you don't know that the patient or the nurse is diverting medication, things like that. You understand? So if you can get your bedside report, get your bedside report. When it comes on to, you know, if something abnormal is going on with the patient, the heart rate, the blood pressure is too high, you know, find out what they did at the time. You understand? But have a mental picture, see what's happening, and at least you can, you know, make whoever is accountable for whatever. If they need to reach out to a provider before you leave, let them go and do it. Because the last thing you want is what? You start your shift and you just get report and you realize that the patient is dead in bed. You don't want that on your back. So if you can go to the bedside and get your report, visualize the patient, look at monitor and all of those things. All right. And then from there, a client on airborne precautions need transport to CT. The nurse should A, transport without precautions since CT is short. CT room just right around the corner. Most of the time, right around the corner. You understand? B, place surgical mask on patient and notify the receiving area. C, wear a gown and gloves only. Or D, cancel the CT. So a client on airborne precaution needs transport for CT. The nurse should A, transport the patient without precautions since the CT is just around the corner. B, place a surgical mask on the patient and notify receiving area. C, wear a gown and gloves only. Or D, cancel CT. Sorry, 1 minute. I'm on the line. All right. So Marva, welcome. Melva Carousel says B. Place a surgical mask on the patient and notify the receiving area. Why did I never put an N95? I don't like the surgical mask part. But anyways, yeah, place the surgical mask on the patient. Because I think about airborne precautions. So it's like B. I thought I saw transport without the precautions. So we're not going to transport without precautions. So I guess if that's what we have, we use it. But the right thing would have been the N95. Make sure you get the patient with an N95 because the patient is on airborne precaution. All right. So place the surgical mask on the patient and notify the receiving area. Wear a gown and gloves only. As I say, gown and gloves only is a no-no. All right. You definitely will be wearing your gown and your gloves because it's supposed to be airborne precautions. So you're supposed to have on your N95, your gown, your gloves. You understand? Your face shield, eye shield, all of those fancy things. All right. Cancel the CT is out of it because the patient definitely needs it. Transporting without precaution since CT is like 2 seconds away. When transporting, it's surgical mask. I always find an N95 and put on them. I always put on an N95 on them. I guess probably because N95 is so readily available. I don't know. But yeah. But Carousel says when transporting, it's surgical mask. I don't know. I guess I'm always putting on the N95 on them. Because most hospitals I've worked at, they always have N95. NCLEX is surgical mask. Okay. So NCLEX is surgical mask, folks. All right. So, and then that would have been the most appropriate one here as well. Carousel. All right. But remember the PPE, like, you know, what the airborne precautions PPE are as well. All right. So for transport, mask the patient if tolerated and notify the receiving area so staff use appropriate precautions. All right. Yes. All right. So placing the surgical mask on the patient and notifying the receiving area is the most appropriate thing. All right. Which action by the nurse best reduces central line associated bloodstream infection? A, replace tubing every 48 hours. B, use maximal sterile barrier precautions during insertion. C, flush with normal saline only. Or D, use clean, non-sterile technique for dressing changes. So which action by the nurse best reduces central line associated bloodstream infection risk? A, replace tubing every 48 hours. B, use maximal sterile barrier precautions during insertion. C, flush with normal saline only. Or D, use clean, non-sterile technique for dressing changes. Please sit down. So which option? So you have a patient that has a central line and you're trying to prevent any form of infection. Which one would have been the best option to prevent that? So Melva says B, use maximal sterile barrier precautions during insertion. All right. Definitely you'll do that. Replace tubing every 48 hours. How often do they change the central line dressing? How often do they normally do the dressing change? Let me look it up. Is every 24 hours? 5 to 7 days? Okay, so 5 to 7 days. All right, flush with normal saline only. No. I use clean non-sterile dressing for dressing change technique for dressing changes. So you want to do sterile dressing change all the time. All right, so it's not a non-sterile. All right, so it's a sterile precautions. 5 to 7 days for your central line dressing change. And use maximal sterile barrier precautions during insertion. All right, so okay. Okay, so 5 to 7 days. Okay. So a central line dressing should be changed every 5 to 7 days, every 7 days for transparent dressings, and every 2 days for gauze dressings. Or immediately if it becomes wet, loose, or dirty. Or just adhere to the facility, the facility instructions or policy. All right. A nurse caring for a patient with C. diff should A, wear an N95 respirator, B, use alcohol-based hand rub after glove removal, C, perform hand washing with soap and water after glove removal, or D, use contact precautions only while diarrhea is present. So I have a patient that has C. diff. The nurse that is caring for that patient should A, wear an N95 respirator, B, use alcohol-based hand rub after glove removal, C, perform hand washing with soap and water after glove removal, or D, use contact precautions only while the patient has diarrhea. So Carousel says C, perform hand washing with soap and water after glove removal. Melva says the same. All right, definitely. Wear a N95 respirator. It's a no. That's a little bit excessive. All right, very, very excessive. Use alcohol-based hand rub after glove removal. No, we need to wash our hand. You understand? We need to wash our hand. Hand sanitizer is not a replacement for our hand washing. All right, it's not a replacement for a hand washing. And if the patient have C. diff, like as soon as you take off your double glove, because I normally double up. I say it's not good to double up, but there are certain things me always a double up on. You understand? So double up on your glove. Well, not double up on your glove, but I'm just saying, like there are certain things. Sometimes you have to double up and take off that one and put it over there because it's a total mess. You understand? But do go ahead and wash your hand with soap and water. Do not come out of the patient room and then take off the glove and go over there and sanitize down and you go and eat a little taco, your little chips. You go and eat a little chips. Like, me not understand. You understand? Use contact precautions only while the diarrhea is present. No, you use contact precautions, throughout the entire time. Not only whenever the diarrhea is present. All right. Welcome. All right. So C. diff spores are resistant to alcohol sanitizer. So hand washing with soap and water is required after glove removal. All right. And that is just, just a standard thing. As soon as you take off your glove, you just go and find a pipe. You understand? Just go and find a pipe and just wash your hand and get that out of the way. Plus, the hand sanitizer, them always dry up your hand. Yeah, them dry up your hand too much. All right, so best practice for preventing needle stick injuries. A, recap needles carefully. B, activate safety device immediately after using without recapping. C, remove needles before handing off sharps. D, use gloves and recap with one hand technique. So best practice for preventing needle stick injuries. A, recap needles carefully. B, activate safety device immediately after use without recapping. C, remove needles before handing off sharps. Or D, use gloves and recap with one hand technique. Carousel says B, activate safety device immediately after use without recapping. All right. Definitely. Melva says B. Yes. So recap needles carefully. Never recap your needles. All right. Never recap your needles. Remove needles before handing off sharps. Remove needles before handing off sharps. No, you don't remove anything. All right. Just drop everything in the bin, the safety bin or the sharps container. Use gloves and recap with one hand technique. No, never recap. All right, never recap. So activate safety device immediately after use without recapping. Do not recap needles. Engage safety device and dispose immediately into your sharps container. So always identify where your sharps container is. And if it means that they're going to walk with a little kidney dish, I know a lot of times we don't really have kidney dish like that hanging around, but walk with your little kidney dish if you know you have a lot of sharps that you're going to be dealing with and there's no sharp container close by. So you can always have it to safely put down in that container and then you go and dispose of it. All right. A sputum specimen for acid-fast bacillus test is ordered. Hi, Frank Mitchell. Thank you from Grenada. Welcome, welcome, welcome. A sputum specimen for acid-fast bacillus is ordered. What's the best time to collect the sample? Is it A, at bedtime, B, first thing in the morning when the patient does a deep cough, C, immediately after breakfast, or D, anytime available? It's 8 o'clock. Yes, go to your bed. So you have a patient that is to give you a sputum culture, a sputum sample. When is the best time to get that sample? Is it at bedtime, A, B, first thing in the morning, C, immediately after breakfast, or D, anytime? So Carousel says B. Okay, nice. Do we have anybody else? Hi, Daddy, registered nurse for over 10 years. Okay, nice, Frank. Nice. Welcome, welcome. All right, no specific time. All right, so the answer is actually B. You want to get it first thing in the morning. All right, first thing in the morning, you always tend to have the best sample for your acid fast. All right, just think of it. If you don't have any specific time, just think of it. You're trying to get a sputum, and probably the patient eat something early in the morning, probably get it a little bit, contaminated, not necessarily contaminated, but mix up with a lot of food or, things like that. So you always want it whenever the patient has just gotten out of bed, the first cough. Yeah, man, just go over there and tell them to cough and give it that nice sample. Put it in your container and send it over to the lab. You understand? So the first thing in the morning after some deep coughing is the best sample for your acid fast testing or your TB testing. Hi, Miss DNP. Welcome, welcome, welcome. And thank you for sharing up the live. All right. And then from there, for surgical asepsis during dressing change, which is correct? So for surgical asepsis during dressing change, which is correct? A, sterile field can be created with a wet sterile glove. B, turn your back on the sterile drape edges if touched. C, keep sterile items above waist level. Or D, reach across sterile field if necessary. So you have a patient that you're going to be doing a catheter, a catheterization on. For surgical asepsis during, dressing change. We're going to do dressing change. That's what the question says. For surgical asepsis during dressing change, which is correct? A, sterile field can be created with a wet sterile glove. B, turn back on sterile drape edges if touched. C, keep sterile items above waist level, or D, reach across the sterile field if necessary. Melva says C, nice, which is keep sterile items above waist level. All right. Sterile field can be created with a wet sterile glove. So Frank says C, which is the same, keep it above the waist level. All right. So sterile items must remain above the waistline. Reaching across is going to contaminate the field. You understand? Turning your back is also contaminating the field. And you don't want to be using anything wet to be handling your sterile field, because that is, you introducing bacteria into that field as well. All right. So you want to keep the sterile items above the waist level based on the answers here. All right. Yes, Carousel. All right. So which immunization is recommended annually for healthcare workers? So which immunization is recommended annually for healthcare workers? Is it A, Tdap, B, varicella, C, influenza, or your MMR? So which immunization is recommended annually for healthcare workers? A, Tdap, B, varicella, C, flu, or D, MMR? Frank says C. Brenela says C, definitely your flu shot. Influenza is usually given annually to reduce infection risk or transmission. All right. A nurse is caring for a patient on droplet precautions. Which PPE is required when within 3 feet? So you have a patient that is that has a diagnosis. The patient is on droplet precaution. Which PPE is required when within 3 feet? Is it A, gown and gloves only, B, the surgical mask and eye protection if splash is anticipated, C, N95 respirator only, D, no PPE if the patient is masked? So a nurse is caring for a patient on droplet precautions. Which PPE is required when within 3 feet? A, gown and gloves only, B, surgical mask and eye protection if splash is anticipated, C, N95 respirator only, or D, no PPE if the patient is masked. All right, so Melva says B, Frank says B, the surgical mask and the eye protection if splash is anticipated, definitely. So droplet precautions require your mask, your eyewear, if you're thinking about any form of splashes. All right. So always remember that. Gowns and gloves only, no, it's droplet. All right, so you definitely want your eyewear. And no PPE if patient is masked is out of it. N95 respirator only is out of it. All right. Your N95 is mostly for your airborne precautions. NCLEX type question, all right, or styled questions. All right. What are the best disposal method for impregnated dressings contaminated with blood? So A, regular trash. Not a problem, Miss G. Thank you so much. Thank you so much. No problem, Brennelou. All right. So best disposal method for impregnated dressings contaminated with blood is going to be A, regular trash in sealed bag. B, dispose in the red biohazard bag per policy. C, flush down trash. Shoot uncontained. Or D, reuse after sterilization. So what's the best disposal method for impregnated dressings contaminated with blood? A, regular trash in sealed bag. B, dispose in the red biohazard bag. C, flush down the trash chute uncontained. Or D, reuse after sterilization. Definitely B. All right, so you want to dispose in your red biohazard bag per policy. All right, so there are different color bags out there. You just have to know what each of them is for. So you have your red, your yellow, you have your regular black bag. Sometimes you might see white, blue, but the red, the yellow, definitely know what those are for. All right, so biohazard waste containing blood requires regulated medical waste disposal. All right, what's the yellow bag for? What's the yellow bag for? Thank you, thank you, thank you for the gift, Miss G. All right. What's the yellow biohazard bag for? We always see them. Is it the same? Is this the same for the so like your chemotherapeutic drugs, what else? I don't think that's all they use in it. They use it for. So yellow biohazard bags are used to contain and dispose of infectious, contaminated, and other clinical waste from healthcare settings, including laboratory materials, pharmaceutical waste, and soiled medical items like dressing swabs and aprons. These bags are essential to preventing the spread of infection and are designed to withstand treatment such as incineration or autoclaving to safely process the waste. All right. All right, so a 24-year-old, Gravida 1, at 28 weeks. So this person has been pregnant only once, all right? At 28 weeks, ask about fetal movements. What is going to be the best response? A, count fetal movements once a week. B, perform daily kick counts. 10 movements in 2 hours is reassuring. C, only seek help if movements stop for 24 hours. Or D, decrease activity to feel more movement. So you have a 24-year-old. This is her first pregnancy, and she's 28 weeks. She's asking you about fetal movements. What is going to be your best response? A, count fetal movements once a week. Is that good enough? B, perform daily kick counts. C, only seek help if movements stop for 24 hours. Or D, decrease activity to feel more movement. What is going to be your best response for this person that is 28 weeks pregnant? So are you going to tell them to count fetal movements once a week? Once a week too small, not true. That's just, yeah, they need to do it every day, right? So they need to perform daily kick counts, all right? So 10 movements in 2 hours is pretty reassuring. Only seek help if movement has stopped for 24 hours. No. You know that if you have a baby moving in your belly and you don't feel no movement in a half hour, you start complaining. So can you imagine not having any movement for 24 hours? No, so only seek help if movement stop for 24 hours. It's just a bit too long. All right. Decrease activity to feel more movement. No, life continues. You understand? Baby will adjust. You understand? Baby will adjust to whatever is happening. But in order for you to, if they want to know about the fetal movement, to tell them, go ahead and do the kick count. All right. And give them a time period or the amount of counts that you're looking for. You understand? To say, okay, then everything is good. All right, and then from there, but counting the fetal movements once a week is just too little. All right, you need to have them be checking that every day. So if there's any change in the movement of the baby, all right, you can always know that, okay, then they need to go out and seek help. So daily fetal movement counts with targets, example 10 in 2 hours, help detect fetal compromise. Prompt evaluation if you notice there is any decrease in the movement. All right. So always have them go about with making sure they're doing their daily kick counts, and then from there. At 6 months, which milestone is expected? So you have somebody who has been pregnant. A child is now 6 months old. What is the milestone that you're expecting for this patient? For them to say 2 words, 2 to 3 words. That's A. B, sits unsupported briefly and responds to name. C, walks with assistance. D, so D is gonna be uses pincer grasp to feed self. So 6 months old, what's gonna be the milestone you're expecting? A, says 2 to 3 words. B, sits unsupported briefly and responds to name. C, walks with assistance. Or D, uses pincer's grasp to feed self. So what's going to be the answer? So at 6 months, you're expecting them to. And if you have children, always just use them. You understand? Use them to answer some of the questions. Just think about what they were doing around that time and look at what the options there if it's something that you're not familiar with. All right. So at 6 months, they would be sitting unsupported briefly and responding to name. All right. At 6 months old. Progressing to unsupported briefly and recognizing name. All right. And pincer grasp emerges later. And let's see what. All right. So the pincer grasp activities use the thumb and the index finger to pick up small objects, strengthening these fine motor skills. Examples include threading beads and pipe cleaners, peeling tape and stickers, snorting small items like dried beans into a muffin tin, using Play-Doh to find small toys, and eating finger foods like Cheerios. All right. So that is later on in life. So the one that they do at 6 months is the one where they're sitting unsupported briefly and responding to their name. All right. A woman with an abnormal pap smear. It says HSIL. What is the next best step? All right. So you have a lady with an abnormal pap smear. What is going to be the next best step? A, repeat the pap in 1 year. B, immediate colposcopy and biopsy. C, no follow-up if asymptomatic. Or D, start hormonal therapy. So you have a patient with abnormal pap smear. What is going to be the next best thing for that person? Repeat the pap smear in 1 year. B, immediate colposcopy and biopsy. Or C, no follow-up is required if asymptomatic. Or D, start hormonal therapy. What is the recommendation for that person? All right. We have anybody over YT who wants to answer that? So you have someone with an abnormal pap smear. Repeating the pap smear in 1 year is just going to be too long. All right. Because remember that this person is now at risk for lesions. All right. So you want to identify what is growing down there. Is it something that is cancerous? So definitely you want to go ahead and have them get that biopsy, the colposcopy, done immediately to identify what is going on down there. All right. And then from there, they are able to rule out any of those lesions. All right. So repeat pap in 1 year is a no. You want to do it a little bit earlier. So they get the biopsy done, see what's happening, then they will go ahead and do the repeat on the pap smear. All right, no follow-up if asymptomatic. Even if they're not asymptomatic, you need to follow up with them. All right, so they can continue doing the pap smear to see if it is changing. The grade of that abnormal finding there in the pap smear is changing. All right, start hormonal therapy. No, don't think that is it. All right, so abnormal pap smear requires prompt colposcopic evaluation and possible biopsy to rule out high-grade lesions. All right. Recommended screening for colon cancer in average risk adults. What is that? So what is the recommendation for your colon cancer in average risk adults? Is it A, colonoscopy starting at age 45 or 50? All right, with repeat intervals per finding. Is it B, no screening until symptoms appear? C, annual CT scan. D, FOBT only at age 70. So the fetal occult blood test. All right, fecal occult blood test only at age 70. So what is the recommendation for screening for colon cancer in average risk adults? Is it A, colonoscopy starting at age 45 and repeat intervals per findings? Is it B, no screening until symptoms appear? C, annual CT scan? Or D, the fecal occult blood test only at age 70? Melva says A, which is the colonoscopy starting at age 45 and repeat intervals per findings. Definitely. All right. Frank says A as well, definitely. So current guidelines recommend screening starting at 45 for average risk. Verify, but go ahead and check with, your updates locally. Colonoscopy interval depends on findings. So depending on what the findings are, then they will determine how often, the frequency of it. All right. No screening until symptoms appear. No, you want to go ahead and do your screening still. All right. Hopefully there's no findings or symptoms. Well, you definitely want to go ahead and do your screening at all times. Fecal occult blood test only at age 70. You can get it before that. All right. You can get it before that. And then from there, because some persons don't really like the testing. So you can always go ahead with your fecal occult blood. And then from there, encourage them to go ahead and get the colonoscopy. All right. 55-year-old male with type 2 diabetes asks about immunization. Which is recommended? So you have a 55-year-old male who has type 2 diabetes. What immunization would you be recommending for this person? A, additional vaccines beyond childhood. B, annual influenza, pneumococcal, and shingles. C, varicella only, or D, HPV vaccine only. So you have a 55-year-old male with type 2 diabetes who asks about immunizations, which is recommended. A, no additional vaccines beyond the childhood. B, annual influenza, pneumococcal, and the shingles vaccine. C, varicella only, or D, HPV vaccine only. So which of them is it? Camille's Legacy welcome says B, the annual influenza, pneumococcal, and shingles as indicated or eligible. Definitely. So B is the answer. All right. No additional vaccines beyond childhood. No, we have boosters and all those things that we have to get, right? So that one is out of it. Varicella only is also out of it. As I say, anytime you see the option with only, just ignore that one because that's not it. You're always going to need your varicella or your chickenpox if you're eligible for it. Your HPV vaccine, usually you'll get that throughout, all right, from a younger age up until adulthood. All right. So the one that is most appropriate for this 55-year-old, the diabetic patient, would be the annual influenza, the pneumococcal as indicated, as well as the shingles if that person is eligible for it. All right. All right, let's go ahead and top up the live, guys. All right, go ahead and top up the live and share it and encourage your friends to come over and answer a few questions with us. All right. Yes, Orion. All right, so best advice to promote bone health in postmenopausal woman. So best advice to promote bone health in postmenopausal woman is A, avoid weight-bearing exercise. B, increase calcium and vitamin D intake and engage in weight-bearing exercise. All right. C, limit protein intake, or D, take unregulated herbal supplements. So you have a postmenopausal woman. What is the best advice you can give them to promote bone health? A, avoid weight-bearing exercise. B, increase calcium and vitamin D intake and engage in weight-bearing exercise. C, limit protein intake, or D, take unregulated herbal products or supplements. So for postmenopausal women, bone health is, bone health is very important for everyone, but for your postmenopausal woman, all right, definitely. So B, increase calcium and vitamin D intake. Do we encourage them to avoid weight-bearing exercise, or do we encourage them to exercise, do light exercises and all? You always go ahead and encourage light exercise, all right? Weight-bearing exercise, all right, because you want to ensure that you're maintaining the bone density, all right? So definitely increase calcium and vitamin D intake, and you also engage in weight-bearing exercise. All right. Would you limit protein intake? Limit protein intake? No. All right. Take unregulated herbal supplements. You always want to make sure you're regulating any medications that you're taking. All right. So unregulated herbal products, no. All right. A teen asks about contraceptives method that reduce acne and regulate menses. What's the best option to discuss? So a teen comes to you and asks about contraceptive methods that reduce acne and regulate menses. What's going to be the best option for you to discuss? Is it A, combination of oral contraceptives, B, a copper IUD only, C, condoms only, D, fertility awareness only? All right, so someone comes over to you and wants to talk about, acne. They want something that is a contraceptive that will help with their acne. All right, and they want to find out what's the best one, as well as to regulate their menses. What's going to be the best one? Is it A, combined oral contraceptives, B, copper IUD only, C, condoms only, or D, fertility awareness only? So Camille says B. Is that B for this one or before? I think probably that was from before. So Lasponia says B, which is a copper IUD only. So no, so the copper IUD is out of it. All right, thank you for the follow. The copper IUD is out of it. Oral contraceptives are always going to be the ones that they, will give them the best effect. All right, the best effect for their acne. All right, as well as with regulating their cycle. All right, so combined OCPs can reduce acne and regulate cycles. So counseling should include the risk, the benefits, and the alternatives. All right, so just read up on those. So that for acne, you always want to do the oral contraceptives with them. All right, combined oral contraceptives. Condoms only is out of it because that's not really doing anything, in terms of their hormone. Fertility awareness only, out of it. Copper IUD, I don't know much about, the copper IUD and acne. All right, but the combined OCPs can reduce acne and regulate cycles. All right. A 60-year-old with hypertension asks about home blood pressure monitoring. What's the best teaching for this person? A, measure once in the morning while lying down. B, take 2 readings 1 minute apart. After 5 minutes rest. Sitting, record values. C, use any cuff size. Placement is not that important. And D, only measure when feeling unwell. So you have a 60-year-old who has hypertension and asks about home monitoring for their blood pressure. What is going to be the best teaching for this person? A, measure once in the morning while lying down. B, take 2 readings 1 minute apart after 5 minutes rest. Sitting, record the values. C, use any cuff size because placement is not that important. And D, only measure when feeling unwell. What's going to be the best answer? So Camille says A, measure once in the morning while lying down. Okay, do we have anybody else? All right, so the answer is to take the 2 readings 1 minute apart after 5 minutes rest when sitting. All right, and record the values. And at least, you're checking for accuracy because sometimes you might be lying down and you check your blood pressure and it's low. All right, some persons it might be high. You just want to do a second check to confirm the reading. All right, so always have them to do proper technique includes resting 5 minutes, seated, appropriate, cuff size, 2 readings to improve accuracy. All right, because what if they take it in the morning and it is elevated, it's high? You understand? They probably run to the emergency room and by the time they sit up, the blood pressure gone back normal. So have them go ahead, sit up, Take the blood pressure 2 times, and then from there they can compare the numbers. All right. Only measure when feeling unwell. No, you want them to measure when they're well and when they're not. All right. Because most of the time, especially if their blood pressure, if they're not feeling well and they go ahead and check their blood pressure, sometimes it can be because of the blood pressure being too high. So you don't want it to be a case where when they're symptomatic is when they're going to be checking it. At least have baseline and have an idea of what the numbers are throughout the day when they're, well, and not really symptomatic. Use any cuff size. No, you always want to make sure you have the appropriate cuff size, because if the cuff size is too small, you might get a very high reading. It's going to be abnormal, or it might be too low. And it's the same thing whenever the cuff size is too large. You might just get, abnormally high reading or low reading. All right, so always make sure you get the most appropriate size to fit the patient. All right. A mother asks when to start introducing solid foods to her healthy term infant. So a mother asks when to start introducing solid foods to her healthy infant. At what age? Is it A, at 2 months, B, at 4 to 6 months when the infant shows readiness, C, at 9 months only, or D, at 1 month if formula fed? So a mother asks when to start introducing solid foods to her healthy term infant. Is it at 2 months, A, B, at 4 to 6 months when the infant shows readiness, C, at 9 months only, or D, at 1 month if the patient is formula fed, if the baby is formula fed? So what's the correct answer? So you have a baby that is 2 months. Can that person get can that person get solid food? No. I know a lot of times some persons tend to do it, but it's not safe. All right, it's not safe because they're thinking about, the risk for choking. So you don't want to give a 2-month-old solid food. That baby don't even come off a breastfeed. You understand? So no. At 4 to 6 months, I'm still probably on the breast as well, but at least, they're probably able to move up. They're doing some fancy things with their tongue. So when they think about giving them something to eat, they probably know what to do with it. All right. 9 months only, you can start from before. So 4 to 6 months is pretty decent. At 1 month, if formula fed, and because the formula fed, it doesn't mean that, they know how to, move around the little food in their mouth. All right. So you have to be careful with that. So solid foods usually begin around 4 to 6 months when developmental signs of readiness appear. So I guess we have to study that as to what are the, the different things that they do at certain age group. All right. And as I say, always think about the risk. Always think about the risk, the safety issue that is there for that patient. All right. All right. Gonna do 3 more questions. All right. I'm gonna do 3 more questions. I think Carousel is sleeping. All right. I think Carousel is sleeping and yawning and probably going to wake up again and just come back and say, yes, A. Let me see if Carousel is in the chat. No. You understand? Carousel sleeping the other night. All right, so we're gonna do 3 more questions. An adult male request PSA screening. All right, and we know what PSA is, right? What's PSA? What's PSA? What is PSA? Hey Trish, welcome, welcome, welcome. All right, so we have our patients with their prostate gland that is enlarged. All right, that antigen there. All right, that's your PSA there. So a male patient requests PSA screening. What is going to be your best response? A, it's recommended PSA for all men annually starting at age 40. B, discuss risk or benefits and individual risk factors. C, refuse because it's not useful, or D, order PSA without discussion. All right, so an adult male requests PSA screening. What is going to be your best response? Is it A, recommend PSA for all men annually starting at age 40? B, discuss risk or benefits and individual risk factors. All right. C, refuse because it's not helpful or useful, or D, order PSA without discussion. All right. So the best answer is going to be what? It's going to be B. All right. So discuss the risk, the benefits. the risk, the benefits, and the individual risk factors. All right. So loyalty says D, order PSA without discussion. No, you have to talk to them about it. You have to talk to them about it. Discuss with them first. All right. All right. So recommend PSA for all men annually starting at age 40. You can, some persons you can start from earlier. All right. You can start from earlier. Discuss the risks, the benefits, and individual risk factors. So individual risk factors, because if this patient has family members who have had prostate cancer before, definitely you want to go ahead and start screening, doing those tests from early. All right. And it's going to be a shared decision as well. So it's not going to be something because you feel like you need to get that PSA done, you're going to go ahead and do it. No. All right. Make sure the patient agrees to it. Refuse because it's not helpful, it's out of it. Order PSA without discussion. As I say, you have to talk with the patient and they have to give you consent on anything that you're doing. All right. So have a conversation about the PSA and then from there. So PSA screening involves shared decision making based on age, the risk, and the patient preferences due to benefits and harm. All right. So always go ahead and discuss with them. Which dietary recommendation helps lower LDL? All right, cholesterol. Is it A, increased trans fat, B, increased soluble fiber, such as your oats and your beans, things like those to decrease saturated fat and to decrease saturated fats, C, avoid all fats entirely, or D, increase refined carbohydrates. So which dietary recommendation helps lower LDL cholesterol? Is it A, increase fats, your trans fat, B, increase soluble fiber such as your oats, your beans, and decrease your saturated fats, C, avoid all fats entirely, or D, increase refined carbohydrates? Increase soluble fiber, definitely carousel, and decrease your saturated fats. Yes, Frank. All right, so increase your soluble fiber. All right, so soluble fibers reduce your LDL, reducing saturated trans fat also lowers your cholesterol. All right, so you don't want them to avoid all fats entirely. No. All right. Increase refined carbohydrates is a no-no. Increased trans fat is also a no-no. Trans fat, no, not good. All right, so definitely you want to increase your soluble fibers. All right. And then the last one here is a 16-year-old with depression reports suicidal ideation with a plan. All right. The nurse's priority is A, encourage the teen to try coping skills. B, remove lethal means and initiate supervised evaluation and possible hospitalization. C, schedule outpatient follow-up in 1 to 2 weeks. Or D, keep it confidential from the parents. All right. So you have a 16-year-old with depression who reports suicidal ideation with a plan. The nurse's priority is going to be what? A, encourage a teen to try coping skills. B, remove lethal means and initiate supervised evaluation and possible hospitalization. C, schedule outpatient follow-up in 1 to 2 weeks. Or D, keep it confidential from the parents. Definitely B is going to be the answer. Remove lethal means and initiate supervised evaluation and possible hospitalization. Encourage a teen to try coping skills. Yeah, they can try coping skills while they're admitted, while we're keeping a closer eye on them. All right. Schedule outpatient follow-up in 2 weeks is a no-no. This patient has a plan. You understand? So make sure you act on the situation right now and then act on the situation, no, because in 1 to 2 weeks, you don't know what that person might end up and do. All right. So you can't really schedule something outpatient for them. All right. Like that. Keep it confidential from the parents. All right. So per law, the parents are supposed to be involved because this child is underage. All right. So per law, and I guess I'm going to say per the state as well, because there's so many things out there. But per law, that child is a minor, so they would have been involved or been a part of, what's going on. All right. So suicidal ideation with a plan requires immediate safety measures, removal of means, and urgent. Removal is important and urgent psychiatric evaluation is necessary. Parental involvement per law and safety is required. All right. So basically that's that. But definitely if anybody has a plan, definitely you do your one-on-one, safety check. You put everything in place to make sure that patient is safe and that patient is not a risk to anybody in terms of, endangering them. All right. So that was our 39 questions for tonight. All right, that was 39 questions for tonight. We'll see you again on Thursday for more questions. All right, we'll see you again on Thursday for more questions. And then from there, but thank you, not a problem, Carousel. I know you drop asleep long time. I know you drop asleep long time. You understand? But thank you so much for coming back to close off the show. All right, but guys, thank you so much for tuning in. All right, it's always nice to be up and be learning again, learning new things, or just having some refresher, something, something refreshing in terms of like some of these questions and answer throughout the night. All right, so thank you so much for tuning in, making it Think Nursing. All right, now we'll see you guys Thursday again for another question and answer. All right, and then from there, I think I'll do some pop-up live. I'm not working tomorrow, so I might be online tomorrow. I'm gonna do my notes first. Thank you, Frank. Not a problem. All right, so I will see you in another live. All right, and on YT here, thank you so much. I don't see you type anything as yet. I don't know if you hide from me or what, but thank you so much for tuning in. At 7 p.m. So it's gonna be Central Standard Time. So I'm in Texas. It's roughly 9 o'clock now. So yeah, I'm gonna try to put it on my schedule so it's on the page all the time. All right, and thank you so much for subbing to the page or following. And if you miss any of the other live stream that we've done live stream on neuro, musculoskeletal, cardiac, GI. All of those are posted to my YT page at Think Nursing. So go over there and subscribe to that page, and you'll see like the full length of the videos. So on Thursdays we tend to go a little bit longer, like probably like 3 hours, 4 hours worth of questions. So definitely those videos are posted over there, and you can always check them out. And if you have any questions, reach out to me and let me know. All right, any on diabetes? Not as yet. We haven't done endo, but I'll create a list of questions, and then we try to study as well. What I'm trying to do as well is try to do like pathophys, like do questions that are more for pathophys focus. All right, so we can actually know where the left ventricle is, the right atrium, things like those, and what they're supposed to be doing. All right, so I'm gonna create some questions like those just for pathophys, sake, so we can understand like the cardiovascular system itself as well. So, but you can always go ahead and send me suggestion as to what you want. I know one person says we can do some. I said I was gonna do ABGs, like EKG type questions. Some persons were saying care plans. So we'll do things like those and just kind of focus on it and study as much as we possibly can through doing questions. All right, so rather than coming and reading, just reading about whatever, just have some questions and we try to just, answer them as it relates to that. So if you have any other suggestions, feel free to go ahead and, send me, and I'm open to, hearing what they are and then plan for that. All right. All right, until then, I will see you in the next live. All right, when I tell you sleep, I feel like how Carousel feeling. I did 45 minutes of workout just before the live here. I'm going to say I'm feeling so tired. Like I'm just feeling it. Probably like 30 minutes, 15 minutes ago, 20 minutes ago. Yeah. All right. So we can always come back and do more questions and then from there. Until then, I will see you in the next video. All right. And remember to go ahead and check out the contents that I'm posting and like the video, share. What else to say? Favorite. Yeah, all of them fancy stuff there. Just go ahead and watch the videos. All right. All right. Until then, later. Bye on YT here.